All right, well, here we are into the second part of the cardiovascular disorders chapter, and as you remember, this is over 800 slides. So I'm going to break it up into about 4 or 5 different lectures. And this part, part 2, deals with the ECG monitor, it deals with the paper, it deals with the complexes, that sort of stuff before we actually start looking at arrhythmias. So an electrocardiogram is the name that we give our heart monitor. What we see on the monitor is actually called an oscilloscope, and it measures electrical waveforms. But the electrocardiogram, the 2-lead or 3-lead or 4-lead or 12-lead piece of paper that we look at, can give us a lot of information about what's going on with the cardiovascular system. We can use it to monitor heart rate, but when you look at your heart monitor, it's going to tell you what the rate is, but that's not always accurate. So you always need to confirm what you're seeing on the monitor with what's actually happening with your patient. So if I'm looking at the monitor and I see that there's a rate of 80, I'm going to feel for a pulse to verify that I in fact have a pulse of 80. We can also use the electrocardiogram to evaluate the effects of disease or injury on heart function. And what we're talking about here certainly is looking for things like Q waves or inverted T's or depressed ST segments or elevated ST segments that would indicate things like infarct, ischemia, and injury. We can use it to determine how well a pacemaker is working, whether it's a pacemaker that the patient has internally or when we do transcutaneous pacing on the outside of the chest. We can use it to evaluate the response to medications, particularly medications that slow the heart rate down, like adenosine, or antiarrhythmics that restore regular, normal contractions, or medications that should allow the heart to speed back up, like atropine. We can hook a patient up to a monitor, particularly if their heart rate's fast or slow, greater than 100, less than 60, or if there's any sort of irregularity when we feel their pulse. And we can get a baseline reading, and that will tell us where they're at before, during, and after we do a medical procedure. We can also, again, use the ECG to evaluate for signs of myocardial ischemia, which will be present when we see inverted T waves or depressed ST segments, or myocardial injury, which will be present when we see elevated ST segments, and infarction we see on the electrocardiogram as pathological Q waves. Some other information that can be obtained by looking at a monitor strip or looking at the heart monitor includes the orientation of the heart in the chest. Your heart sits on an axis, and sometimes, like the Earth, it may deviate one way or the other, to the left or to the right. And as the heart changes its orientation in the chest as a result of enlargement or failure or injury or those sort of things, we can see changes on the paper that would indicate a left axis deviation or a right axis deviation. We can look at the monitor strip to see whether or not we have any conduction disturbances like premature beats, abnormal beats, block beats, that sort of things. And again, looking at the heart monitor, we can determine the electrical effects that perhaps medications have on the heart, but more importantly, electrolytes. We can look at a heart monitor and know whether or not a person's potassium is too low or too high. We can look at a heart monitor to determine the mass of the cardiac muscle, or how large the muscle is, or how strong the muscle is, or how much electricity is going through the muscle, and we'll see those when we get to identifying things like left ventricular hypertrophy. And then we can, again, look at that heart monitor and determine whether or not our patient has inverted T waves or depressed ST segments that would indicate the presence of ischemia. Now, in order to see the electrical activity of the heart, we have to have electrodes that hook to the patient's chest through patient cables, and the patches or the electrodes contain conductive media They stick to the skin most of the time unless the patient is really diaphoretic. And the conductive media, that jelly that's located in the center on the sticky side of the patch, allows or picks up the electrical charge much better than if it were dry or if it were placed over a bony prominence. Then we have to make sure that our cable, our patient cable, is attached to the ECG machine or the heart monitor. And when everything's wired for sound, when you've got the patient hooked up to the electrodes, the patient cable plugged into the monitor, and the monitor turned on, you'll be able to measure the electrical activity that's occurring in the heart. And we do this with an ECG monitor, and one of the skills that you'll be practicing in your lab would be hooking up a heart monitor, whether you're using 3 leads or whether you're using 4 leads or 5 leads or even doing a 12-lead ECG. First thing you have to do is power it on, make sure the patient cable is connected to the monitor, snap your electrodes onto your leads, and I like doing this rather than putting the leads on the patient's chest and then trying to snap the electrodes on. Sometimes you got to push pretty hard to get them to snap on, and if it's already stuck to the patient's chest and you're pushing really hard to get the electrode attached to the cable, that can be painful for the patient. You want to prep the skin before attaching the electrodes, and this is something that's often missed and not done, and it should be done prior to hooking up any electrodes. One, using just dry gauze, shaving hairy areas, or even using an alcohol pad to get rid of the oil and dead skin so that you get a better adhesion of the electrode to the skin, which is going to give you a better tracing as well. When we're connecting the patient up to a heart monitor, most heart monitors these days use 4 or 5 leads. There's a few out there that have 3 leads, and the 5-lead models, they have a white electrode which goes above the second intercostal space but below the clavicle, and then they have a black electrode which goes in the exact same space, the exact same spot on the left side of the patient, and then they have a red electrode which goes down around the 8th intercostal space, often mid-axillary line, and a green electrode which goes on the exact same space, the exact same spot on the right side of the patient, and then a chest lead which is usually brown. And that goes just to the right of the sternum in that 3rd intercostal space. And that's your standard 5-lead placement. If you had just 4 leads, then the chest lead would be absent. If you had just 3 leads, then the chest lead and the right leg would be absent as well. Once you have your patient all wired for sound, plugged in, ready to go, you want to have your patient relax, because things like muscle tremor, movement, will cause artifact and make it very difficult for you to identify the rhythm. Most monitors do some sort of calibration when you turn them on, but you may have to adjust the ECG size of what you're looking at, particularly if there's not a lot of voltage. If the patient is really thick-chested, or if they just don't have a lot of electricity going through their heart, the complexes may be very small and hard to see, so you might have to turn up the ECG size in order to see them. Again, what you see on a monitor is electrical and does not necessarily correlate to mechanical pumping function of the heart. So it's important that you check a pulse and compare the two. Look at what the heart monitor says the rate is and feel what the patient's rate is. Okay? By default, most of these monitors have heart rate alarms that are set, but if your patient is running a really, really slow heart rate, you may have to lower those alarms. And the alarms are there, of course, to do that. If you're busy in the back and the heart rate gets going too fast or too slow, you'll get an audible alarm to, hey, look at the monitor. You want to print a strip initially to identify the patient's initial rhythm. You want to interpret the rhythm, but also assess how the patient is dealing with that particular rhythm. Just because a person has a slow heart rate doesn't mean that we need to treat them. If they're a well-conditioned athlete, then certainly a slow heart rate would be normal for them. And then once you run a strip, there's a variety of ways now that those strips are being attached to the patient care record or the patient care report. Some are being Bluetoothed and electronically uploaded to software that you write your patient care report in. Others are still printing them out, taping them on paper, and scanning them in, or just putting the paper version in the patient care report. Now I had mentioned the electrodes, and we're talking about the leads here. Leads, lead 1, 2, 3, 4, 5, 6, 7, 8. We got all 12 different leads when we do a 12-lead ECG. Leads record the electrical activity between two electrodes, and each lead records the average current flow in different planes. There's a frontal view that looks at the heart from the front of the body. There's a horizontal view that looks at the heart as if the body were sliced in half horizontally. And then there's a 12 lead. And a 12 lead looks at the heart from 12 different angles. It's like taking a camera and snapping a picture and taking 2 steps to the right and snapping a picture and 2 steps to the right and snapping a picture and working your way around the chest so that we get 12 different pictures of what's going on with the heart. Okay. Each lead has a positive electrode or a pole, and when there is no electrical activity being measured, that is known as the isoelectric line or the baseline. You can see here in red where the isoelectric line is identified. Between some of these waves and complexes, there is a relatively flat black line, and that represents no electrical activity at all. And that's known as the isoelectric line. As electricity flows from a negative pole to a positive pole, the electricity is measured in an upward deflection or a positive deflection above the isoelectric line. If the electricity is flowing from positive to negative, then the opposite is true. You'll get a negative deflection below the isoelectric line. And the reason that this is important at all is that we learn all our rhythms, or we'll be learning all our rhythms in lead 2. And the whole purpose of lead 2, excuse me, that wanted to go to the web page when I clicked on it. The whole purpose of lead 2 and why we like to monitor in lead 2 is that the complexes are upright. So we like to monitor in a lead where our P waves are going to be upright and easy to see, our QRSs are going to be upright and easy to see, our T waves are going to be upright and easy to see. And then we're better able to pick up things like inverted T waves and elevated ST segments and depressed ST segments when we monitor in lead 2. Lead 2 follows the flow of depolarization or the flow of electricity as it travels through the heart. Now you have your standard limb leads, leads 1, 2, and 3. They're known as bipolar limb leads, and the reason they're bipolar is that depending on which lead I'm looking at, let's say lead 1, which looks from the right white electrode across the chest to the black electrode. So that's lead 1, and in that particular situation, the white is negative and the black is positive and the red is neutral. But as you change leads, the poles change. When I look at lead 2, the white is negative, and now the red is positive rather than neutral. The black becomes neutral in lead 2. So that's why they're called bipolar leads. The positive electrode is at the left wrist in lead 1. The left foot, leads 2 and 3 have positive electrodes, and so that's what that's referring to. When we place these electrodes on the patient's chest, we want to try to put them between the intercostal spaces rather than directly over big bony prominences. We don't put them directly on the sternum. We don't put them directly on the clavicle. We want to try to avoid those so that we get better tracings. Here's a diagram that identifies the axis of the leads, and this triangle is known as Einthoven's triangle, and it just identifies the polarity of the leads depending upon which one you're looking at. You see the axis of lead 1, the right arm is negative, the left arm is positive, but when I look at lead 2, the right arm stays negative, the left foot is positive. When I look at lead 3, the left arm is now negative instead of positive, and that left foot is positive. So that's the flow in which the electricity travels. And remember, when we're going from a negative to a positive, our complexes should be upright. So typically in lead 1, 2, and 3, our complexes should all be upright. Our P wave should be upright, our QRSs should be upright, our T wave should be upright, and especially lead 2, the axis of lead 2. You can see going from the right arm to the left foot that's the direction the electricity flows in the heart. It starts up in the atrium and goes down to the ventricles. So lead 2 gives us our best picture of our complexes. Okay? So with our lead 1, 2, and 3, lead 1 records differences in electrical potential between a positive and a negative. Lead 2 records the difference in electrical potential between the left leg and the right arm. Lead 3, the differences in electrical potential between the left leg and the left arm. Now unipolar leads are called unipolar leads because they have only one pole. And in this particular case, the heart is the negative pole. So the white lead is positive, the red lead is positive, the green lead is positive, and the heart remains as a negative pole. So the white, red, green, those don't ever change polarity. And the augmented limb leads are called augmented limb leads because the electricity generated by that lead is so small that you wouldn't be able to see it unless it was augmented or boosted up. So they have to identify the fact that the electrical activity that you're seeing in AVR, AVL, AVF is in fact augmented. AVR, if we go back to that slide, AVR is augmented voltage right arm, AVL is augmented voltage left arm, and AVF is augmented voltage foot. The chest leads are also unipolar, with the heart being the negative pole in this particular setup, and V1 through V6 all being positive. V1 is to the right of the sternum in the fourth intercostal space, and it looks at the septum. V2 is to the left of the sternum in the fourth intercostal space, and it looks at the septum as well. V3 is midway between V2 and V4, and it looks at the anterior portion of the left ventricle. V4 is the midclavicular line, fifth intercostal space, and it looks at the anterior portion of the left ventricle. V5 is left anterior axillary line at the same level as V4, and it looks at the lateral portion of the heart, as does V6. It's in the left mid-axillary line at the same level of V4, and again it looks at the lateral portion of the heart. Because of the way that these leads are situated on the chest, going from left to right, with these electrodes placed on the chest, going from right to left, what you'll see is a progression of the R wave that begins below the isoelectric line, and as you continue around the heart, the R wave progresses to where it's almost all above the isoelectric line, and that's known as R wave progression, and that's something that we look for when we're looking at a 12-lead ECG and we're looking at leads V1, V2, V3, V4, V5, V6. We want this gradual progression of the R wave to where we have a nice QRS there in V4, 5, and 6. Okay, so here is where the electrodes go, as we had mentioned. V1 is in that fourth intercostal space to the right of the sternum. Excuse me, V2 is in that fourth intercostal space just to the left of the sternum. V4 is mid-clavicular line in that fifth intercostal space, and V3 is halfway between V2 and V4. And then we go down to V6 and put it in the mid-axillary line, and V5 is halfway between V4 and V6. And the whole purpose of doing a 12-lead ECG is that we take these 12 different pictures of the heart and we can put them together and we can see the big picture. We can see what's going on. We can identify which coronary artery is occluded. We can identify which part of the heart is affected, as well as the type of arrhythmia we might expect to see. There are situations or times where we may want to do what's called a right 12 lead. And when we have a person who shows elevated ST segments in leads 2, 3, and AVF, those are the inferior leads, and they look at the right coronary artery. And in about 25% of the population, if that right coronary artery is occluded, it may affect that right ventricle. And if the right ventricle is affected, it's really susceptible to decrease in preload. So if I've got a person having a right ventricular MI, they're going to have chest discomfort, and they're going to want things like aspirin and nitroglycerin and morphine. But when I give them the nitroglycerin, their blood pressure is going to bottom out because that right ventricle isn't working well as a pump when it's infarcting, and then I go and decrease the blood supply coming to it. So it pumps little or no blood at all, and the blood pressure drops significantly, and the patient can arrest. So when I see a normal 12-lead ECG, when I see elevated ST segments in leads 2, 3, and AVF, I'm going to pick all those electrodes up on the left side, with the exception of V2, and I'm going to move them over to the exact same spot, but on the right side. And then I'm going to redo the 12-lead ECG, and I'm going to make sure that I put, by V6, I put an R, or I write across the top of it a right ventricular 12-lead. What I'm looking for here is elevated ST segments in right V4. If I have elevated ST segments in right V4, then that tells me that that right ventricle is involved, and we probably shouldn't be giving them nitroglycerin. Sometimes if we suspect or we want to get a look at the back of the heart, because we really have no leads in a 12-lead ECG that look directly at the back side of the heart or the back surface of the heart, what we can do is we can move those leads on the left side further around towards the back. All leads are placed in the same horizontal line as V4, 5, and 6. So, we call them, when we do move those leads from the left side of the chest to the back, and on that same plane or on that same line as V4, 5, and 6, and we go across the chest with those leads, if we were to run a 12 lead, we would have to note that this was a posterior chest lead. Lead V7 is at the post-axillary line. V8 is placed at the angle of the scapula, and V9 is placed over the left border of the spine. and then you can also move those 3 electrodes over to the other side on the right side and do a right-sided posterior ECG. It wouldn't be a 12 lead, but an ECG. And that just gives us a picture of what's going on the posterior portion of the heart. I don't know many people that do this, but it can be done. That's where you get terms like 15 lead ECGs or 18 lead ECGs. You have the 12 on the front, and then you've got the 6 on the back. I went backwards. So that's the 15 lead ECG, and when you add the other 3 there on the right, that's the 18 lead ECG. Now your ECG paper is graph paper that has small and large boxes that are measured in millimeters. And when I go from left to right, looking at those small boxes, I'm looking at time. When I go from bottom to top, looking at those small boxes, I'm measuring voltage. And each small tiny box on that paper, from left to right, equals 0.04 seconds. So 5 small squares, or 1 big box, would equal 0.2 of 1 second. Now when I go from bottom to top, 1 small square is equal to 1 millimeter or 1 millivolt in energy. So 5 small squares, which make up 1 big square going from bottom to top, would equal a 5 millimeter increase in voltage. The vertical axis going from bottom to top measures voltage, like I had said, and it'll have a positive value if it's above the isoelectric line, a negative value if it's below the isoelectric line, and it's measured in millimeters for height and millivolts as well. 1 millimeter equals 1 millivolt in the measurement from bottom to top of those small boxes. The other thing to keep in mind is that machines, when you turn them on, calibrate themselves. And a calibrated machine, a 1 millivolt signal will produce a deflection measuring 10 millimeters tall, and that tells you that the machine is calibrated. Alright, so we've got this patient all hooked up to the monitor, and we've got all these squiggles on the screen, and we have to identify what these squiggles or these waveforms are. The P wave is the first waveform in the cardiac cycle, and it's the first abrupt yet gradual movement away from the baseline, and it returns back to the baseline. It's well rounded and above the isoelectric line, and the P wave represents the depolarization of the atrium, or the spread of the electrical current through the right and left atria, and it eventually will proceed, and the next waveform that we see is going to be a QRS complex. Now P waves can be normal, upright and rounded as it shows there. They can be notched, like the second one. They can be peaked. They can be inverted. Obviously we like to see them upright and rounded. If they're notched, that may not be coming from the sinus node. Same thing. To improve audio, close, switch to telephone. Hopefully you still can hear me. I'm just about done with this, so we'll continue on. So P waves take on different looks. If they're coming from the SA node, then the P wave is going to be upright and rounded. The QRS complex has a Q wave, an R wave, and an S wave. And this results as the electrical impulses spread through the ventricles. So it represents the depolarization of the ventricular tissue. But not every QRS has all 3 waves. The R wave is the first positive deflection. The S wave is the negative deflection following the R. And the R and S waves simultaneously represent the depolarization of the right and left ventricles. The Q wave is the first negative deflection following the P in lead 2. Now, if the complex is entirely positive, then all you have is an R wave. If the complex is entirely negative, then you have a QS. If you have a 2 plus deflections are present in the same complex, then the second one is called R prime. So you have an R and an R prime. And you'll see that with a bundle branch block. If you have 2 negative deflections in the same complex, then you have an S and an S prime. And the width of the complex is measured from where the first complex wave begins to move away from the baseline until it comes back to the baseline. And normally that width is no greater than 0.10 seconds, or we like to just reference it as it's no wider than 0.12 seconds, no wider than 3 small squares. So here's just an example of your electrocardiogram and how QRSs aren't really QRSs. You may have a QS as there, you may have a QR, you may have a pathological Q and an R, again a pathological Q and a small r, small q, regular R, regular S, and that's typically what most people have. If you don't have a Q wave at all or an S wave, then you just have an R. And there's an RS with no Q, then there's a small r and a deep S, then there's a small r, deep S, and an R prime, and then a R and a small S. So we call them all QRSs, but understand that depending on which lead you're looking at, that might be what it looks like. Okay. T wave represents the ventricular repolarization, or the resting and the recharging of the ventricles. The slope of the T wave becomes abrupt and gradually steeper, and then it ends and returns to the baseline. It should be less than 5 millimeters in height. It should be less than 5 small squares in height in any limb lead, and it may be greater than should be greater than 0.5 millimeters in height in leads 1 and in leads 2. The T wave should follow a QRS complex and should be in the same direction of the QRS. However, if the QRS is abnormal, then the T wave is going to be abnormal. As an example, when I'm looking at a PVC, or a premature ventricular contraction, the QRS is going to be in one direction and the T wave is going to be in the opposite direction of the QRS. Your T wave may also be very tall or pointed, or what we call peaked. And when we see tall or pointed or peaked T waves, that indicates that the patient may be hyperkalemic. So here's an example of some different types of T waves as well. You have some T waves that look relatively normal in those first 2 set of complexes. And then as you go further, you have some T waves there at the end. The last 2 are peaked. You have some inverted T waves in the middle. So T waves take on different looks, and they tell you different things. Normal T waves tell you there was normal repolarization through the ventricles. Inverted T waves will often indicate ischemic tissue. Peak T waves indicates hyperkalemia. Now, a U wave is a wave that we rarely ever see. It's a very small waveform. When it is seen, it does follow a T wave, and it represents the repolarization of the Purkinje fibers. The heart rate has to be pretty darn slow to see it, and it's very difficult to identify anytime the heart rate's greater than 90 beats a minute. And if you do see it, it's tallest in V2 and V3, and it's usually in the same direction as the T wave. And the U wave, when seen, can be an indication of hypokalemia, not enough potassium in the blood. If you look at this 12-lead ECG and you look at those different T waves in lead V4 and V5, primarily V4, you get a really good look at it in V4 and V3, that little small hump after the T wave. that is a U wave. Segments are something that we also measure because time is everything when we're looking at complexes, and the PR segment is the PR interval. The PR interval is a horizontal line between the beginning of the P wave, or the end of the P wave. The PR segment is begins at the end of the P wave and ends at the beginning of the QRS. It represents the time that the AV node holds that electrical charge before letting it go through the bundle of His down the right and left bundle branches and into the Purkinje fibers. And that is the time where that atrial kick occurs, where the atrium are able to dump all their contents and then begin repolarization. So there's the PR segment there on that PQRST complex. And we also measure the TP segment. That's between the T wave and the following P wave. It's usually isoelectric. In rapid heart rates, you can't measure it because everything is so close together. Now the ST segment is another segment that's very important to us when we're looking at rhythm strips. And the ST segment is between the QRS complex and the beginning of the T wave. And it's used whether the final wave of the QRS is an RS or not. It represents the early repolarization of the right and left ventricles. So here you can see the ST segment identified, and if the ST segment is elevated, that might be an indication of injury. If the ST segment is depressed, that might be an indication of ischemia. And when I talk about elevated or depressed, I'm referring to its reference to the isoelectric line. If the ST segment is elevated above the isoelectric line, then that's injury. If it's depressed below the isoelectric line, then that's ischemia. Now, some things that we didn't mention were intervals. The PR interval you can see from the beginning of the P to the beginning of the QRS. That should be no wider than 0.2 of 1 second. So somewhere between 3 and 5 small squares would be the PR interval. The QRS width should be no more than 3 small squares. And then the QT interval in normal rates should be under 0.38 seconds. Now that has to be adjusted with rate, because the faster you get going, the closer everything gets together and the shorter your QT interval is. The importance of the QT interval is people with prolonged QT intervals are at a greater risk of sudden cardiac death. So when we talked about ST segment elevation and ST segment depression, that is something that is measured from the J point. And there's an example of where the J point is. So from the J point, we look at that ST segment and we say, is it above the isoelectric line more than 1 small square? Is it depressed below the isoelectric line more than 1 small square? And if it is, it might indicate injury or ischemia. And that's just what this slide says, that the ST segment displacement, whether it be elevated or depressed, may indicate ischemia, injury, or infarct. We look to see if it's elevated above the baseline or is it depressed below the baseline. In order to measure that, we have to find the J point. You can also use the TP and PR segments. Those should be flat. Those should be isoelectric. So you can use those to determine where the isoelectric line is, and then compare the level of ST segment elevation or depression to determine whether or not there is injury or ischemia present. And for it to be meaningful, as we'll learn when we learn about 12-lead ECGs, is that ST segment depression or that ST segment elevation has to be seen in 2 or more leads that look at the same part of the heart. If I have elevated ST segments in just one of the 12 leads, that doesn't really mean anything. Okay, so here they're talking more about the PR interval again, and the PR interval usually between 3 and 5 small squares in length. When that becomes longer, you're looking at what's called a first degree AV block. When that becomes short, less than 3 small squares, you're looking at a condition known as Wolff-Parkinson's White. The QT interval, again, that represents the time from ventricular depolarization through repolarization, and it starts at the beginning of the QRS complex and it ends at the end of the T wave. The duration depends on age, gender, and heart rate, but it should be no wider than 0.38 seconds. Again, when the heart rate's really fast, it's going to be much shorter than that, but it shouldn't be any wider than 0.38 seconds. As the heart rate increases, the QT interval is going to shorten, so you have to adjust to heart rate. And an abnormally long QT interval would be something that would be over, in this slide it said more than 0.44 seconds. In order to determine the QT interval in really fast heart rates, where everything is so close together, what they want you to do is measure the distance or the time between one QRS and the next QRS, and then divide that by 2. And that will give you your QT interval that you use when looking at faster heart rates. The RR and the PP intervals, they help you determine the rate and regularity of your rhythm. If you measure the distance between your QRS complexes, that should be equal all the way across the paper. The R to R, QRS to QRS, you're looking at ventricular rhythm regularity, and if you measure your P to P from one P wave to the next P wave, that distance should be the same all the way across the paper. You're looking at atrial rhythm regularity. Now, artifact is something that may show up on an ECG, and it can be the result of a variety of things, but it makes it very difficult to interpret the rhythm. Loose leads, dry electrodes, loose cables, loose wires on the monitor itself, muscle tremor, patient movement, doing CPR or 60-cycle interference are all types of artifact. Now, when I'm analyzing the heart rate, there's a methodical steps that I take. Even though I may look at a rhythm and say, you know what, that looks like this arrhythmia, I need to be really careful when doing that. You should take an approach when you're looking at rhythms so that you look at certain things each and every time and answer certain questions before identifying or interpreting the rhythm. One of the first things we look for is the rhythm regularity. And that is looking at the distance between the P to P or the R to R. They should be the same. It should be nice and regular, as you see here. So rhythm is something that we analyze. The regularity, if the distance between the QRS complexes is equal all the way across the paper, then the rhythm is regular. If the distance is not the same all the way across the paper, then the rhythm is irregular. Now, irregular rhythms come in two varieties. We have regularly irregular, much like a wallpaper pattern, where you can see a pattern of irregularity marching across the paper, or it could be irregularly irregular, like we see with atrial fibrillation or ventricular fibrillation, where there's no regularity at all. There's no pattern to this irregularity. It's just irregularly irregular. Now, there's a variety of ways to determine heart rate. That's another thing we want to assess, whether the rhythm is fast or slow or normal. And normal is 60 to 100. Less than 60 is bradycardic. Greater than 100 is tachycardic. And so we want to know what the rate of the rhythm is. And one method is the 6-second strip method. And back a couple slides, you'll note that on ECG paper, they'll put 3-second marks at the very top of the paper. So 2 of those 3-second marks would be 6 seconds. And I can count the number of complexes in a 6-second strip and take that times 10, and that will give me the number of heartbeats in a minute. A second method is to count the number of large boxes between one QRS and another QRS, and then divide that number of large boxes into 300. The same would hold true if you wanted to know the atrial rate. Measure the distance from P to P and divide those large boxes into 300. Another method is the 1500 box method, where you take the number of small boxes and divide that into 1500. And you can do the same for the atrium. So here's an example of the 6-second strip method number 1 up top. I would look at those dark vertical hash marks at the very top of the paper, and 3 of those would equal a 6-second strip. And I would count the number of complexes in that number of QRSs in that 6 seconds, and there would be 8 there. So the rate would be 80. So 8 times 10, the rate would be 80. Using method 2, I could count the number of large boxes, 1, 2, 3, 4, and I could divide 4 into 300. And dividing 4 into 300 would be 75. Okay, so that's a little more accurate. I could take the number of small boxes and divide into 300, so I could take 18 small boxes and divide that into 300 as well, and I'd come up with somewhere around 76. So you're not going to get exact numbers when you use these different methods. My favorite method is this 4th method. It's called the sequence method, and the reason I like it is I don't need a 6-second strip. I need to know I need 2 QRSs, and when I look at the distance between R to R, I can determine rate by looking at the distance between an R to an R. And what you do is you select an R wave that's on a dark vertical line, and then you count forward each vertical line. 300 is the next vertical line forward, 150 is the next vertical line, 100 is the next vertical line, until you get to your QRS complex, and then that will give you your number. So if you look here, I have a QRS complex on a dark vertical line, and as I count forward, the next vertical line would be 300, the next vertical line would be 150, the next vertical line would be 100. So my heart rate here is 100, and this is the most accurate method in determining the heart rate. So it requires you to memorize 300, 150, 100, 75, 60, 50, 40, 30, but it is the most accurate method of determining heart rate. The other thing you have to do in analyzing a strip, besides regularity and rate, is do I have P waves for every QRS? If I have more P waves than QRSs, then I have a heart block, and I'll need to figure out which one that is. But do I have a P for every QRS? And do they all look alike? If they all look alike, they're coming from the same spot. If they look different, then they're coming from different spots. So I want to look for P's in my QRSs. I also want to start measuring my intervals. Is my PR interval 3 to 5 small squares? Is my QRS width less than 3 small squares? And is my QT interval within normal limits? Because again, if the PR interval is too long, you're looking at a first degree heart block. If your PR interval is too short, you're looking at WPW. If your QRS width is too wide, you're looking at perhaps a complex that's originating in the ventricles, or is being slowed, or the conduction is being slowed either by medication or injury in the ventricle conduction system. And then you look at the QT interval to know whether or not certain medications will prolong the QT interval. So you'll know that if the medication is doing it, or are they just one of those people who have a abnormally long QT interval and are at risk of sudden cardiac death. So you're going to measure your PR interval. Remember, it's got to be less than 3 to 5 small squares. You're going to measure your QRS width. That's got to be less than 3 small squares. And you're going to measure your QT interval. And if it should be less than half of the R to R interval. And that would be normal. Okay. You're also going to look at the ST segment. If it's elevated or depressed, that might give you an indication that you're dealing with ischemia or injury. You're going to look at that T wave. If the T wave is inverted, that's going to indicate ischemia, and if it's peaked or pointed, that's going to indicate hyperkalemia. So once we've interpreted the rhythm using these steps, what is the rhythm, what is the rate, is there a P for every QRS, is my PR interval normal, is my QRS width normal, is my QT normal, is my ST segment, is my T wave inverted or peaked, is my ST segment elevated or depressed. Once I've done all that, then I can identify where the rhythm is coming from and what it's doing. When we start naming arrhythmias, we do this by identifying the first name tells you where it's coming from, and the second name tells you what it's doing. As an example, when I say ventricular tachycardia, well, I know it's coming from the ventricles, so it's going to look a certain way, and it's tachycardic, so it's got to be greater than 100. So that helps us name our rhythms as well. Alright, so we finished with this, and next we're going to get into actually identifying and naming rhythms based on all this newfound information on the complexes on an electrocardiogram. Questions? Give me a shout, or look me up on email. Thanks, and I will talk to you soon.